So what's the definition of osteomyelitis? So the osteomyelitis, the main thing is, it means the infection of the bone. But where is the infection? The infection lies inside the marrow. So it is not a superficial infection, it is the infection that affects deep inside the bone. And you need to understand this, it is not a very easy thing to happen. It takes a long time, and there are definite clinical features of the features of infection that are there presents in the phase of an acute osteomyelitis. You have read in pathology how an acute infection presents. There will be redness, there will be swelling, there will be pain. So that are the same things that presents in an acute osteomyelitis. So it is more of a clinical diagnosis. There won't be much of the radiological thing. Radiology, X-rays doesn't show much. And if you really want to pick it up, you need to do in form of an MRI. So MRI picks up the osteomyelitis better. Only when it goes to a chronic osteomyelitis, it becomes easier to pick up on plain X-rays. But you need to understand there are certain differences between an acute phase and there is a chronic phase. And the features are completely different in acute osteomyelitis than in chronic osteomyelitis. So it's an inflammation of the bone caused by an infecting organism. It remains localized. It may spread through the bone to involve the marrow, cortex, periosteum. So we need to understand this, how to classify it. So classification is based upon the duration and the type of symptoms. So the most common one, that is the acute and the chronic. The mechanism of infection. So it can be a hematogenous route, it can be a lymphatic route. And the type of host response. So let's see. So there is acute when it's less than 2 weeks, subacute 2 weeks to 6 weeks, and chronic when it is more than 6 weeks. Osteomyelitis can be exogenous. So it's based upon how the bacteria or the microorganism is lodged into your bone. It can be a open trauma. A patient sustains a fracture, has a road traffic accident. From the site of injury, the microorganism entered into the bone. So it can be trauma or surgery. When the surgeon is operating from an operating room also, it can get inside the bone. So let's see at the etiology. So the most common organism, if you ask what is the most common cause of an acute osteomyelitis, it is Staph aureus, Staphylococcus aureus. And this chart you can take a snap. It is just important for your exam purpose, because if a short note comes on acute osteomyelitis, you have to know what microorganisms are there. So you just have to tell in infants what is the most common, that again is Staph aureus. In children over 1 year, which is most common, that is again Staph aureus. And if it in adults also, if it is most common issue, that is also Staph aureus. So Staphylococcus aureus is the most common organism that is usually associated with a acute osteomyelitis. So the most common route, if you see, that is the hematogenous osteomyelitis. Many patients come with infection that is lodged somewhere else, but you may present with an infection in a bone, deep pain inside the bone, and that comes through the hematogenous route. But one of the most important reasons, you have to know that where in the bone this is most commonly happens. And this again you can just take a snap. There is nothing to tell about this. This again is very much theoretical. Just you have to, for exam sake, I am just completing the slide. That again Staphylococcus aureus is the most common. If you see the other group of organisms, we have the coagulous negative staph, we have the Enterococcus, Streptococcus, and the Salmonella species. Okay, this again is, I think you guys have all read this in pathology. Okay, so let's come directly to the orthopedic part. Okay, so why Staphylococcus aureus is most common? Okay, first of all, it is most common because it is most commonly present also. In the normal skin flora also, you can see a Staphylococcus aureus is there. So there is increased affinity for host protein. We have the enzymes. This again is microbiology and pathology, enzymes and surface factor A. It forms biofilms. It has adhesive proteins and glycoproteins, and that makes a defensive mechanism, and that's why the body's native mechanism, like immune system, cannot fight against it. And that's why persons whose immune systems are not that good, old age patients, children, infants, are more prone to have this infection. Okay. Epidemiology, this we can skip. This is again nothing to do with orthopedics. So yes, let's come to this. Which bone is most commonly affected? Tibia is most commonly affected. So this you have to know. Why? Because it is shin bone. It is just underneath your skin. Whenever you see any accident, tibia is the most common bone that sustains an open fracture. Open fracture, most common organism which is present on the skin and in the surroundings, the Staph aureus gets inside the bone, is an ideal host for infection. Next question that will come, which part of the bone is most prone to have this kind of infection? You have to remember it is the metaphyseal epiphyseal junction, because you have the end loops. So the blood vessels goes from the diaphysis, it goes to the metaphysis, and there it forms loops, hairpin ends. Because the blood flow becomes sluggish near the metaphysis, the bacteria gets stuck over there, and that's why it becomes a more ideal recipe for the infection. So how the pathogenesis, again take a photo of this. There is nothing much to say, everything is self-described. But what is most important, what I have told you, is the location of the bone. So that you have to remember always, metaphysis is the most commonly affected area. Which patients are more susceptible? Systemic and local causes, patients with low immune system, patients with diabetes, patients on steroids, chronic steroids. I mean mainly the immunosuppressive patients. Immunosuppressed patients, two age groups you have, the elderly group and the young children group. And the next common thing that happens are the patients with immunosuppression. Okay. Bacterial factors, nothing to say, this is all pathology. Yes, so this is important slide. Where it occurs in the metaphysis of the long bones. Why it occurs? Because there is precarious blood supply, has a decreased activity of macrophage, and the main thing that happens is what I told you, the end loops. That is important. I think there will be a photo. Yeah, this is the main thing. So this is what happens. If you see, this is the diaphysis of the bone, middle part. This is the metaphysis and this is the epiphysis. So the diaphyseal vessels goes, it forms loops. This is the growth plate. So the blood vessels won't go into the epiphysis from the metaphysis. So the blood goes and it forms loops because the blood flow becomes slow. That's why it forms an ideal place where the bacteria can grow. This is what I want you to understand from this class. Rest, everything is there in pathology. Take a photo of this slide. Why metaphysis is involved? This is the thing which you have to write in your orthopedic exam. Okay. So when if the short note comes, which area is more commonly involved, this is what you have to write. You can skip this. So these are the pathology which will be taken part in the chronic osteomyelitis part. So you have to understand chronic osteomyelitis. So the thing what happens, the blood gets slow, bacteria gets lodged, acute phase of infection features, that is your inflammation, redness, swelling, all of this happens. Gradually the bacteria grows, the bone dies, and when it dies, it forms sequestra. The dead bone is called the sequestra. And around that sequestra, new bone starts forming, and that is called the involucrum. Okay. So that are all features of chronic osteomyelitis. I won't be telling this because in the next class that will be dealt with. These are all, we will go to the next thing. Involucrum also we will, so this is important. So what are the clinical features of acute osteomyelitis? You have to very clearly understand that acute and chronic are two different things, and you have to know the features of acute and chronic separately. Acute, see what is there? Red, heat, pain. There is all the features of inflammation. There will be a deep tenderness. So this is important to understand. So if a patient comes with redness, swelling in the tibia after a trivial trauma, you are pressing it, tremendous amount of pain, you are seeing redness, always suspect acute osteomyelitis. Acute osteomyelitis is purely a clinical diagnosis because there are not many patients who are affordable to do an MRI. So that you have to understand. And X-rays won't give you much. If you are very good in reading X-rays, you can find there is some amount of soft tissue swelling, but it's very difficult to pick up in acute phase. So if an acute osteomyelitis patient comes, it is more of a clinical diagnosis, and you have to treat them by an empirical IV antibiotic. So it has to be an intravenous antibiotic. You have to admit the patient, you have to give intravenous antibiotics. Usually it resolves. But if it is missed, and if you are not doing that, then what will happen? It will turn into a chronic osteomyelitis. Okay? Clinical page. So what are the laboratory findings? This again, if a short note comes in the exam, this you have to write it under this. So the leukocytosis will be there. The total counts will be raised more than 20,000. Sometimes blood culture, if you do it, you can get the organism. If you aspirate inside the joint, you can get thick pus. So these are all the findings that you can get in a patient, okay? X-ray findings are usually negative. So that's what I was telling. If a patient comes acutely, X-rays are usually negative because it takes almost 6 weeks for sequestra and involucra to happen. Unless that happens, you cannot pick it up on X-rays, okay? Let's get to, so another modality is ultrasonography. Ultrasonography can pick up, but again, it's not very positive predictive value for that. Bone scan, radioisotope scan has a very good prediction value, but it is very costly test. Majority of the centers don't have it, but it has a very, very high predictive value. So sensitivity of this test is very high. So you have the technetium 99M scan, which can pick it up. You have the MRI, which is the investigation of choice for acute osteomyelitis. So it can pick it up very nicely. You will see in the T2 dense images, you will see a lot of hyperintensity, and it is a very good investigation to pick up an acute osteomyelitis. So early diagnosis, it's more of a clinical diagnosis. Patients presenting with acute illness, rapid onset, severe onset pain, deep tenderness, total counts more than 20,000, and technetium 99 scanning or MRI scanning, which will help it pick it up. Okay? So this again is, so let's go to the treatment part. So how will you treat? So the general treatment is you have to splint the limb. You have to splint it. Suppose it is affecting the tibia, you cannot let the patient bend the knee and move forward. You cannot do it. Give him rest, give him ice, give him compression, give him splinting. So this is the basic things that you have to write in the exam. So the main idea of a theory class is not to throw everything at you. It is just to tell what you don't know and what you already know, what you can use your pathology skills and write it in the exam. So in the orthopedic exam, you are expected to write orthopedics, not pathology. So I'm telling only those parts which is important for you. So for an acute osteomyelitis, give the rest, limb to rest. That is, you have to give splinting in the form of, you can either give a knee brace or you can give a POP slab. So it depends upon it. Give ice compression so that the local inflammation comes down, and give antibiotics. So antibiotic therapy is always has to be an empirical intravenous antibiotic. No oral antibiotic role in acute osteomyelitis because it is already inside the blood, it is already inside the bone. An oral antibiotic, if you give, the bioavailability of the drug reduces. So you want maximum bioavailability of the drug. So that will happen only if you give intravenous antibiotics, and that has to be at least for 2 to 3 weeks. Okay? Surgical treatment is only for chronic osteomyelitis and only reserved for those acute osteomyelitis where you can palpate there is some amount of pus there, but it is not responding to IV antibiotics. Usually patients get better if you do these two things. Okay? So what are the complications of acute osteomyelitis? Today I am speaking of only acute osteomyelitis. That's why I am skipping the slides in between. Previous year, I used to take both the classes together, but this year another person is going to take the chronic osteomyelitis. So I'm just covering the acute osteomyelitis part. So what are the complications? So first complication is it can turn into a chronic osteomyelitis. It can go into a septic arthritis. I showed you it is very near to the growth plate. So it can affect the physis and there can be a growth disturbance. If it gets dislodged into the blood and there is a complete septicemia, it can be life-threatening. And pulmonary embolism and DVT are very, very rare. But if it comes like acute osteomyelitis, a topic comes in your exam, these are the 3-4 points that you have to write. Okay? So that completes acute osteomyelitis. So what are the topics, the headings that you have to do? First, definition. Next, etiology. Third, pathomechanism. Why it is happening, where it is happening. Fourth, clinical features. Fifth, investigations. Sixth, treatment. Seventh, complications. So these are the headings. Okay. So just for a revision, I will be telling introduction. It is an infection that happens inside the bone marrow and associated with all features of inflammation that presents with pain, swelling, redness, and functionalacia, that is loss of movements. So all the features of inflammation. Etiology, how it happens, most common that happens is it is through a hematogenous route. Second, it can be a direct inoculation through a traumatic route. It can be a iatrogenic, that is through a surgeon's role in an operating room. What is the most common organism? Etiology. Under etiology heading, you have to write which is the most common organism. That is Staphylococcus aureus. Other groups that are present are Streptococcus group. It can be coagulase negative Streptococcus. And you have to remember the slide photo that I have showed in infants and in children, in adults. This you have to write. Which are the more susceptible group? You have to always keep in mind the infants and the elderly people. These are the more susceptible groups who are more prone. Patients who are immunocompromised, HIV, on immunosuppressant drugs, on cytotoxic drugs, on steroids, and on patients with diabetes mellitus. This completes your etiology. Next comes pathogenesis. So the most, you are expected to write only the hematogenous pathogenesis, okay, not the traumatic or the direct inoculation. So you have to write like this. Bacteria lodged into the blood goes to the metaphyseal end. Because of the end loops, there is a sluggish blood flow. Bacteria become stagnant over there. There is more growth of bacteria and the disease proliferates. And if you are able to draw that diagram, very good. After that, clinical features. Clinical features, you have to write like signs and symptoms. Always define like signs are what you are seeing, symptoms are what patients are coming with. So the same things as inflammation. I'm not going to repeat that. After that, after the clinical features, you have to write management. Under the management, you have to write what laboratory findings you are getting. Laboratory findings, you have to write there is, if you are doing a total count, there is leukocytosis. If you are doing an aspirate, you will get a pus, and this is all you have to mention. After that, you have to do the treatment. Treatment I've already told, give rest to the limb, give ice compression, give IV antibiotics, and splint the limb. Okay? And complications, first complication that you should always write, it can turn into a chronic osteomyelitis. If you are not careful, it can turn into septicemia. Okay? And the rare causes like pulmonary embolism or DVT. Clear? So that is what is acute osteomyelitis for you guys. Nothing more than that. Any questions on acute osteomyelitis? Then I will be telling it, or anything extra you want to know. We will deal about the chronic osteomyelitis in the next class, and you have two questions that comes from chronic osteomyelitis. One is Sequestra, another is Involucrum. But acute osteomyelitis, I think 2 to 3 years back, one question came, a short note on acute osteomyelitis. So you need to know what you have to write. So if you write under headings, there is more option for you guys to score marks, because every heading carries 1 marks. So always try to write under headings, and it's very easy. If you understand why it is happening, you don't even need to memorize it. Everything is in flow. And why bacteria gets adhered, that phagocytosis, that protein A, protein B, that you guys know better than me. You guys are just past pathology. Okay. But for the core orthopedics is the main thing is why it gets affected in the metaphysis. That is one concept that you have to understand. Another concept you have to understand, it is not picked up on X-rays. It is more of a clinical diagnosis. Only MRI or a bone scan can pick it up. And how do you approach a treatment?